Thank you all for coming today. It's so good to see you all, some familiar faces. Welcome to our August 2025 Virtual Gastroparesis Awareness Month program series. And today we are so honored and humbled to have the distinguished Dr. Thomas Abell with us today, who's going to be speaking on gastroparesis syndromes. Dr. Abell, thank you so much for coming today.
Well, my pleasure.
Yeah, my name is Mary Angela de Grazia de Tucci. I'm a longtime patient with digestive motility disorders, including gastroparesis. I also am humbled to serve as a volunteer for the Association of Gastrointestinal Motility Disorders here in Massachusetts. AGMD is its nickname, and we are an international nonprofit organization. We serve as an educational resource for gastrointestinal motility disorders. We also are an information clearinghouse for those in the medical, scientific, and nutritional communities. And of course, we provide a form of educational support for patients and their families. This program is made possible by a grant from Intera Medical, in addition to the sponsorship of Evoke Pharma. Again, thank you so much, Dr. Abell, for taking the time to be with us today. Dr. Abell, can you tell the audience, and I'm sure so many people know you because so many people registered today, can you tell people a little bit about your background who may not be familiar with your background?
Sure, yeah, Tom Abell. I'm here in Louisville, Kentucky, but I was originally trained, originally from South Dakota, so I was trained as a primary care doctor. But my work as a primary care resident was really in motility disorders. So I went back, while supporting myself practicing, went back and did a research training at Mayo Clinic, and then went on and did more medicine, GI training. So I've been functioning as a gastroenterologist for decades, focusing on motility disorders. So I've been, since I left Minnesota, I've been primarily in the Mid-South, Tennessee, Arkansas, Mississippi, and now Kentucky. But it's a pleasure to be here today.
Thank you. So, Dr. Abell, can you tell us about the gastroparesis syndromes?
Sure, I've got some slides here, and what I was going to say is I can go ahead and talk, and then if there's time at the end, I certainly am happy to answer any questions, or I can answer those later by email too.
Great, thank you. All right, we're ready.
You ready? Okay, I'm going to expand this. Let me know if you can't see, or in the chat if you can't hear me. I've got a southern South Dakota accent, not unlike Tom Brokaw, who I grew up on the street from, but he speaks a little differently than I do. So my main funding is from the NIH, which has supported us for 20 years on gastroparesis, but we actually have two other NIH grants right now, and I've been an investigator, consultant, reviewer, and editor, and we have some intellectual property, but that's not active right now. Some items may be off-label, and I prefer generic names, but we end up talking about trade names sometimes in the questions, particularly. So what I'm going to do is first talk about a current approach to GI motor disorders, especially gastroparesis, since this is Gastroparesis Awareness Month. Then talk about new diagnostic tests for gastroparesis. I have three that I'd like to mention, and three newer therapeutic options. But as I'll talk about, there's lots of options. And I'll talk briefly about the status of drugs with the FDA. As some of you are aware, that's been in flux, as many things are in Washington right now. So I'll talk about that and then have time for some questions. So when we see people, and I still see people one afternoon a week, there's usually an awareness and then a referral. We look at records, they see them, we do history and exam, and we do assessments, but we also include not only diagnosis, but we look at the patient-reported symptoms, nutrition, and quality of life, get a plan, try to initiate that, and then do some follow-up. And that's probably the kind of process that all patients have undergone. Standardly, a lot of things include endoscopy and imaging. A lot of times it's radionuclides with transit measures, routine and sometimes special laboratory. But we also do, in our clinic, we do a lot of electrogastrograms, which I'll talk about. We do nutrient panels, immune measures, and other specialized lab measures. And that's going to vary depending on where people are seen. I'm going to talk about some new diagnostic tests, but first I'm going to talk about body surface mapping. I'm not going to talk about autonomic measures, which are helpful but not widely used. I'm not going to talk about pyloric measures too much, except a little bit under therapy. And I'm not going to talk about full thickness biopsies, but whenever someone has surgery and gets the opportunity for a biopsy, we try to encourage that, because that's the way to look for nerve and muscle abnormalities. And then we try to look at other medical problems, of course, to maximize medical management and personal quality of life. And lastly, we always try to talk about families. My background as a primary care doctor, I'm particularly interested in families, but families make all the difference, as you know, in support and survival. So here's the first diagnostic test. And I did some of the basic science for this test, but I don't have any involvement with this commercially. I do have an NIH grant, however. And this is body surface mapping, which is a high resolution electrogastrogram. Many of you are familiar if you've had esophageal manometry. It's called high resolution manometry, which uses multiple electrodes and impedance measures. This is a way to measure on the surface of the body multiple electrodes, just like we used to do in the operating room. And there's a recorder, and there's also a mini iPad. Patients record their symptoms. So here's a sample of a patient. You see that's like a big bandage that goes on. And there's the recorder on the side. And then there's a picture on the side there of the bandage. And then they sit in a chair. We do this like gastric emptying. So it's 4 to 5 hours fasting, and then a small meal. And then we like to see how quickly the stomach does or doesn't work. And it works, as we know, slowly, as we appreciate sometimes it's too slowly. And we get recordings. So we look at things like frequency. This is the frequency, how often electrical signals are recording. And we look at the amplitudes of the signal. And we also look at, here's a meal, fasting, a meal, and fed period. And there's usually the frequency goes up a little bit and the amplitude goes up a lot. This is a normal recording. But if you look at patients, this is how we look at the stomach, actually, with electrical signals starting up in the upper stomach and going down, getting faster as they go down. But we've discovered, just like in the heart, you can get arrhythmias in the stomach. You can get conduction blocks. You can get reentrant phenomenon, just like with the heart. So ordinarily, though, again, the frequency is stable, goes up with the meal. Amplitude stable, goes up with the meal. But here's some examples of patients where you can see there's no normal frequency here. It's all over the place, dysrhythmic. And the amplitude, in this case, the amplitude doesn't go up with the meal. So we consider that there's probably damage to the nerves. We call the interstitial cells of Cajal, named after Ramon y Cajal, the Spanish neurologist who won the Nobel Prize in 1908. And this is, we get numbers out for a given person. We have normal numbers, but we look at these numbers and see if somebody's profile. I'll give a couple more examples. Here's somebody that has pretty good frequency. The amplitude goes up. If you look at their symptoms down here, which I didn't show in the previous slide, symptom burden here, showing it here, the symptoms go on. And we consider this symptoms track the gastric amplitude, and we consider this visceral hypersensitivity. We have these names where we call people phenotypes, not that we don't care for people and depersonalize people, but we try to think of names that lead us to the best treatment. Here's another example. Some frequency, but then it goes away. Some good amplitude, but it goes away. And the symptom burden is almost continuous. So we think of these patients as maybe having inflammatory disorder or something centrally mediated, which usually means things like cytokines, a word you may have heard, or I call them cytounkines. They're not good for you. It's a measure of inflammation. Anyway, that's body surface mapping, and it's now FDA approved. We have an NIH study that's going to go on for several years trying to show its validity, but I think it's increasingly available in the United States and elsewhere in the world. So talking about that, I'm going to go on to another diagnostic test, and that is looking at transit studies. We used to have something called the Smart Pill, which is no longer available, and not because it didn't work, but because the company didn't want to support it for various reasons. And so we were left with a void. There's another capsule now that's come out like the Smart Pill. It seems to work well. But I'd like to talk about this one that's called the Atmo capsule that works on evaluating gut transit times. And it uses a much like the Smart Pill. And we wanted to compare the two to make sure they were the same. And the Atmo works differently because it measures fermentation. Some of you are aware of people who have bacterial overgrowth syndromes. This measures fermentation as a way to determine. So we measured the Atmo capsule versus the Smart Pill, and we looked at them and compared them. I won't go through all the different mechanisms we use for sensitivity and specificity, but we had 346 patients and subjects. 85 were controls, and 61 that had suspected dysmotility were included, and they included some patients of ours here in Kentucky. And basically, about a quarter have delayed gastric emptying, and about 20% have delayed small bowel transit, 2% have delayed colonic transit, and another 20% have the whole gut delayed. So this is important because even though we say people have gastroparesis, many of them have more than gastroparesis. Many of them have constipation and colonic problems, have small bowel problems. So there was little difference, a minor difference between the two pills. And now this Atmo, as well as the other one that replaced the Smart Pill, have been approved, and the wireless motility capsule can identify delayed transit and whole gut transit. And the nice thing about that doesn't require any radiation, doesn't require any endoscopy, just swallowing the capsule and wearing a receiver to capture the data. The third thing I like to talk about, and these are things that we presented at the ANMS, American Neurogastroenterology and Motility Society meeting early August in Minneapolis. And like most of the scientific meetings, patients don't usually come. Some of the patient representatives sometimes come. I personally, as a former primary care doc, would love a meeting where patients and physicians came together, like happens in some other support areas, but that hasn't happened yet in motility. Maybe it will in the future. But this is a study looking at antibodies, because we've known that some people with gastroparesis-like syndromes have autoimmune antibodies. Some people have diagnoses of things like lupus or scleroderma or other connective tissue diseases. So we wanted to look and see if these antibodies, by a new technique called quantum flash chemoluminescence technique, and we did a pilot study of 18 that I'll talk about, and 12 were normal and 6 were high. And these were people with 18 consecutive patients with symptoms of gastroparesis. We also looked back later at some of our other NIH studies where we had 43 participants, diabetic and idiopathic, and lots of measures. And we're still analyzing that data. But what we did look at was our 18 patients. Here's the high measure, normal measure. And these are some of the antibodies that are sometimes seen. Smooth muscle antibody, Rho60 antibody, or SSB. SSB is worth talking about because it's part of the Sjogren's syndrome. Again, some of you may have been diagnosed with Sjogren's syndrome. So anyway, those all found up. This was borderline significance. The other two were significant. So we think this technique that's not available yet commercially, but we think this technique might help pick up some patients, just like we do with the body surface mapping, just like we do with the wireless motility capsules, and now with these other assays. And our conclusion is that the chemoluminescence may correlate with classic autoantibodies. And we're trying to look now to see if symptoms, physiology, and on other measures might give us, again, these what we call phenotypes. Now, the reason I wanted to present research today, usually I just talk in general terms, but the research is because I think it's very discouraging to have a chronic illness in general, particularly one that's poorly understood. It's not, the illnesses aren't clear and the solutions aren't clear. So it's easy to get discouraged, but I wanted to let you know that lots of people are working hard trying to understand more about these illnesses, with the idea that if we understand the illness, then we can do something better to treat it. So what about newer treatment options? Well, I have usually the Ds, 5 or 6D, not a grade of D, hopefully a grade of do. But there's diet, which I'll talk about in a minute. Drugs I'll talk about briefly. Devices I'll talk about more. Disruption endoscopically, which is a hot area, I'll talk about. Detoxification, which are immune mediated. And then what I won't talk much about, but is crucial, is duration, social, family, and other supports that allows patients to survive these chronic debilitating illnesses. So there's a long history of the best diet for gastroparesis. Many different diets are used. As you know, there are books, Living with Cooking for Gastroparesis, that are excellent. Some patterns have emerged from our gastroparesis consortium, like carbohydrate intake. The average gastroparetic patient absorbs about, or intakes about 80% of their diet in carbohydrates, which is not what we all learned in school we should do, but they can't tolerate fats and can't tolerate protein sometimes. So that's one reason why many of our gastroparesis syndrome patients are overweight or even obese, which wasn't really true 40 years ago when I started out in this area. But it's because we do have nutritional supplements, but they're largely carbohydrate based, and the diets are limited. Now we're hoping that the new GLP and GLP-1 drugs, GLP-1 and GIP drugs, may change this as we learn about weight loss. But unfortunately, those drugs have side effects of causing gastroparesis, among other side effects. So they're not for everybody, but we're hoping we're going to learn more about weight and weight loss and diet patterns from all this work that's going on. So drugs, many are established drug classes like dopamine drugs, dopamine blockers, 5-HT4 agonists, and 5-HT3 antagonists, and 5-HT4 agonists, and NK1 drugs. The dopamine drugs are like Reglan, which unfortunately not recommended for long-term use. The dopamine blockers, domperidone, which sadly has been harder to get recently. The 5-HT3 drugs are things like Zofran and antagonists, which is not a promotility drug, but used by many patients if they can metabolize it for nausea. 5-HT4 drugs can include things in the past like cisapride, which is only rarely available. And now prucalopride, approved for constipation, but has a side effect, or an additional benefit of emptying the stomach well. In the NK1 drugs like Amend or tradipitant, aprepitant or tradipitant, one of them is on the market and one's investigational. But these drugs are all in the process of trying to get more interest from the FDA. And the FDA is our friends. I'm not critical of them, but like many things in Washington, they've been in flux. There are also other drugs used for neuromodulation, not stimulation, but neuromodulating drugs. They're all used off-label, many of them primarily psychiatric drugs, and they can be helpful. The problem is they would say dirty drugs. They're not clean. They don't work on just one receptor usually, and so therefore they're not always tolerated. Although some patients get a lot of benefit from them, and I don't want to minimize that. I'd like to talk about the FDA, particularly with domperidone basically not being available anymore through a program that was set up a number of years ago by a number of people, including myself, advising the FDA. There's scientific data that it's a good, safe drug. The support groups have supported having this available. Right now, we're left with political approaches where I used to say, email or write your congressman. Now I have learned it's hard to do that. You have to contact the central agency and get a permission to contact your congressman. You can't just get their email anymore. You can call them up, but patients are all voters. And so I would, if you're interested at all, I would encourage your elected representatives to be aware that we need access to more drugs, because many of these drugs are available outside the US, but not in the US. And the right to try, and it was popularized under President Trump in his first term, has helped some of that, but we're still left with a lot of drugs that we'd like to try. And the goal is, or right to try idea is to let patients decide themselves, hear the good and bad, possible benefits, possible drawbacks, and then decide. So I wanted to mention that as an unpaid political announcement. So what about devices? Many devices have been tried for gastroparesis symptoms. There's one approved for gastroparesis that I've had a lot to do with for drug refractory diabetic idiopathic gastroparesis. We'll discuss other devices in this study briefly, or other uses of the stimulator. Most of these devices, including auricular stimulation and vagal stimulation, most have vagal effects. And the source of intense investigation, as you may know, a vagal stimulator was just approved for rheumatoid arthritis as an inflammatory drug just last month. And so there's going to be people interested in that for GI motor disorders, Crohn's disease, gastroparesis, and other disorders that involve inflammation. So I'm going to talk a little bit about GI symptoms and physiologic measures in patients undergoing bioelectric therapy. This was at ANMS. And we looked at patients, again, this is, some of this data is off-label. We looked at patients with gastroparesis and functional dyspepsia that can have simpler GI symptoms. In fact, we can't tell them apart in the office. And our NIH consortium had a group for them called gastroparesis-like, but another word for them would be severe functional dyspepsia. And we also were interested in whether increased energy of the stimulator would increase gastric emptying. So we looked at 314 patients, basically half delayed and half non-delayed by standard gastric emptying. And symptoms were measured by a standardized PRO scale. Look at foregut and hindgut domains. So we're interested in hindgut as well as foregut. The assessments occurred at baseline after roughly a week of a temporary trial and 1 year following permanent. And we looked at correlations and regression analysis, which are standard analyses using our software, which is a open source software. So they differed in their gastric emptyings, but differed in no other way. Baseline vomiting and urinary symptoms correlated with the functional dyspepsia group with baseline mucosal EGG amplitude and cutaneous EGG frequency. And in gastroparesis patients, the other group, the 1 year symptom improvement of anorexia, bloating, abdominal pain were associated with the baseline proximal mucosal amplitude. That's low resolution mapping. So there's some physiologic parameters that correlate with outcome with this device. Here's what you see, the two groups for gastroparesis and functional dyspepsia. And you see the temporary trial always gets better numbers than the 1 year follow-up number, but they're almost all, except for one, infrequent urination, they're all significant. And the next slide looks at what happens to gastric emptying. It starts out baseline at 31% of the gastroparesis group, goes down to 23. And at 1 year, it's identical, it's 23. So that baseline emptying improvement you see at 1 week, and it persists. And here's the functional dyspepsia baseline non-delayed 3.2, and with the trial at borderline delayed 10.2. So it slows normal or even rapid emptying, and it's 10.6 at 1 year. Also significant. And again, this is off-label, but the patients all benefit. So I'm going to talk a little bit about another use of gastric emptying and gastric motility with a second group, body surface mapping, that we talked about in our diagnosis. We looked at that with a small group of people getting electrical stimulation. and it's established therapy, but ways to predict response are not always clear. We look to see whether body surface mapping can predict responders to stimulation. And we looked at people getting GS implantation. In this case, we looked at temporary implantation. And then we did the body surface mapping with the baseline meal and then 4 hours of recording. We looked at these things: frequency, BMI adjusted amplitude, and the rhythm index, and also fasting and fed amplitude. And we looked at GES before and after temporary stimulation. We looked at 36 patients, and of those 36, there were 9 that had pre and post. And things like analysis of nausea, vomiting, pain, fullness, all were reduced significantly post-GES. And we found no specific metrics in the people with or without the stimulator. But we looked at univariate analysis. We found that BMA adjusted amplitudes and also at baseline, we had some frequency measures too. And whether clinical markers in gastric emptying did not predict response, but BMI adjusted amplitude did. So there was a difference here. So we're hopeful as we do more. We've now done about 40 of these patients. As we get up into higher numbers, we'll hopefully have a better idea. So in interim analysis, the body surface mapping markers may predict response to GS using a low rhythm index and BMI adjusted amplitude. So frequency and amplitude. And study recruitment is still ongoing, so we'll have some more results soon. The third thing I want to talk about, well, it's the second part of diagnosis is pyloric dysfunction. We use a thing called pyloric flip, which I could have put under diagnosis, but we use it in terms of trying to determine whether pyloric therapy, whether it's G-POM, chloroplasty, or POP, different ways to do pyloric therapy. We wanted to see a flip, which measures the flexibility or the distensibility of sphincters, is helpful. And pyloric trials are mixed, but G-POM is now most actively studied, with about 60 to 70% of people with G-POM improving significantly. But we wanted to see if flip would be helpful. So we wanted to see if the symptoms of gastroparesis with previous interventions with pyloric flip could be a guide. And we use botulinum toxin, which some of you had, and the pylorus has been shown to help some patients improve their symptoms and compliance. And we wanted to see whether those patients who had previous prior interventions had long-term benefit with flip and botulinum toxin. And we did this retrospectively at 61 patients. They all underwent pyloric flip. We gave Botox if the sensibility was less than 10 millimeters per millimeters of mercury, and that's standardized at 40 millimeters in the balloon. Anybody that does this is familiar with this way we do it. There were demographics and gastroparesis and flip metrics were all different, and we couldn't find a difference between improvement. But we did look at some other measures that I'll show you here in a minute. Among 40 patients with an abnormal distensibility index and flip and Botox injection, about 40% responded to improvement and the rest didn't. But the improved patients had an increased pyloric diameter versus the non-improved. And that was right at significance. So it looks like that pyloric diameter makes a difference in improvement after Botox. And the improved group had more normal mucosal EGG, so they were more normal in their EGG amplitude and frequency. And the post-intervention in the improved group, some other flip measures were different. So although there were no differences in baseline, the follow-up gastric emptying time or symptom subscales did show some importance. These are all just the numbers here that we use to compare. But the important thing is that here's the bloating severity post-flip, for example, total upper GI pre, and here's the EGG frequency amplitude ratio and the amplitude here. So these did vary in people whether they responded to Botox. So if you have refractory gastroparesis and you undergo this flip procedure with Botox prior to endoscopic or surgical intervention, those with the highest pyloric flip diameter show the most improvement. And there's since been a couple of articles published saying basically the same thing. So we're going to go ahead and try to get this published now, and try to do further profiling of patients for better selection for pyloric therapy, because 60 to 70% improvement is great, but what about the other 30, 40%? What can we do for them? So I'm going to talk last among the areas I talk about is detoxification. And the reason I talk about that is because we have patients that have a lot of antibodies in their blood and have gastroparesis symptoms. And the immune dysfunctions known to exist in gastroparesis, most common test used is the antinuclear antibody, which some of you probably had. Intravenous immunoglobulin, which is has been used widely, but has some drawbacks. It has to be given intravenously. It has to be given for once a week for 12 weeks or similar, but has some advantages, which I will talk about. The role of prolonged intravenous IVIG in patients with gastroparesis and functional dyspepsia. So again, we're using it with a wide spectrum of disorders. All had nausea and vomiting symptoms. We know that IVIG has helped some patients. It's certainly in the neuromuscular world, which is adapted from our colleagues in neurology. It's used widely. It's available on the market, but it's against off-label. We had this open label trial of gastroparesis and functional dyspepsia. So we had 93 patients, almost 100 patients. 66 had delayed emptying and 27 non-delayed emptying. We gave 12 weeks of IVIG once a week. That's weight-based dosing. Patients can get some discomfort, so they often give them Benadryl and Tylenol beforehand. And we wanted to see if there was a 1.25% decrease in symptom score. And we compared the results. Now, realize that these are people that have pretty much failed everything. Drugs, devices, endoscopy, surgery, they have failed everything. So how did they do? The patients were largely Caucasian females. There were no difference in symptom responses based on race, sex, or say age, age, sex, or BMI. But overall, about 40% of patients showed improvement in vomiting long term. And it was similar for where there was gastroparesis functional dyspepsia. So although 60% didn't improve, 40% of people that were thought to have disorders that could not be treated. So I'll show some examples here. This is the group that didn't improve, 54, the group improved, 39. Here's the non-improved in the blue green. Here's the improved in the red orange. And here's the symptom: vomiting, nausea, loss. This is 12 weeks beyond, 12 weeks and beyond. You see some things like vomiting, nausea, anorexia, bloating, even pain and reflux improved. Constipation doesn't always improve. Diarrhea did improve. Frequent urination did improve. Frequent didn't. That's for the gastroparesis group. Here's a similar for non-delayed emptying: vomiting, nausea, anorexia, bloating. And see, some of these things improve at 12 weeks, some of them don't. Some of them improve longer than 12 weeks. So many of our patients end up on this longer. Our biggest drawback in getting people started on this is getting insurance to pay for it, because it is expensive. But on this ongoing open-label trial of IVIG therapy, patients with both gastroparesis and non-delayed emptying functional dyspepsia showed significant improvement with long-term IVIG. And that's about 40% of them did. So we'd like to do a double-blind randomized study. The problem is we haven't been able to get funding for that because we haven't gotten an agency to support it because it's so expensive to do these studies. But we're still hopeful that we can, because that's what's really needed to make sure this goes into the mainstream. So let me give a summary here. I got a little bit over my half hour, but these gastroparetic syndromes are not rare, and the symptoms may be common. There are new diagnostic tests and new treatments, drugs and devices available. Disruption, detoxification may help. Diet, of course, is always important. But the main thing I want to mention is that hope and support are critical. Hope that there are new things that are being worked on, that there are lots of people, despite disruptions in funding and other things, we're still working to try to help patients improve their lives. And support from families, friends, support groups are crucial. I gave another talk similar to this to another group, and I gave some presentations at the ANMS, and I'll give another one for our Kentucky GI Society this weekend. So I wanted to thank the funding agencies, regulatory agencies, drug and device manufacturers, hospitals and clinic staff, referring providers, colleagues, support groups, and especially patients and families. And I'm open to any questions, and I'll work with AGMD. If I can't answer, I'll work on a way to respond. So let me stop there. I hope you're able to see and hear, and let me stop there.
Thank you so much, Dr. Abell.
So,
Excellent information, very, very informative. A lot of people, as you can imagine, responded with some questions. And I'm going to go out in the audience in just a minute. If you have a question, there's a little icon that you can click on, which shows that you're raising your hand, and you can click on that. But because we got so many, I just want to summarize a couple. And some people had asked, is gastroparesis rare?
well, it depends who you ask and where you look at. Obviously, in our clinic, it's not rare. If you look at the worldwide data from Rome Foundation, it's about 1.8% of the population, and higher than that in the U.S. That's the worldwide data. So it means probably 2 out of 100 patients have classic gastroparesis. If you look at things like nausea and vomiting, and you look at the UCLA survey, it's about 9% of the population in the last 2 months has had some episodes of nausea and vomiting. So I think you could argue that 2% is rare, but I don't think you can argue that almost 10% of the population is rare. So I think it depends who you ask and who you look for. But every gastroenterologist has patients like this with these symptoms in their practice, whether they've been diagnosed with gastroparesis or not, or whether their emptying was delayed or not.
I wish a lot of the practicing gastroenterologists had a lot of this information, because I hear from a lot of patients, they go to their gastroenterologist and the gastroenterologist either dismisses them or treats them with the standard, either Reglan or erythromycin, limited options, or if the gastric emptying study comes back normal, the patient still has those symptoms, it's kind of, well, go home and live with it. So I'm getting a lot of feedback from patients. And of course, some find remarkable doctors like you, Dr. Abell. So how can we get this information trickled down to more gastroenterologists, perhaps some that aren't neurogastroenterologists from motility experts, but to even the general gastroenterologists, besides the patients, coming to us or going to the doctor and trying to explain them? You have any suggestions for patients? Because I saw some bobbleheads here, patients going, yes, yes.
Couple thoughts. I actually want to make one other comment, but the first comment is the Gastroparesis Consortium set up by the NIH is basically there to try to educate other gastroenterologists and primary care physicians. So that's our primary goal. And as a former primary care doc myself, I got into this because I saw these people in the office, and I said, nobody knows anything about this. And 45 years ago, they certainly didn't. We know a lot more now. So part of it's getting the data that is known out. The other thing is terminology matters. We had one of the other support groups, we did a survey of whether what terminology, because some people have used the gut-brain terminology rather than neurogastroenterology, and the patient in that survey didn't like what the gut-brain use of that word. They didn't think it was a good term. whether you agree with it or not. As a physician, I think when patients don't like something, I think we got to find something better. So there needs to be other terminology, and I think instead of just saying you've got a gut-brain disorder, we have to say, well, you've got something in your gut that may affect your brain and how you respond. But the problem is here, in my opinion, is in the gut primarily. So that's that poster was at DDW, and we're working on a manuscript on that survey. But it's all boils down to education, and that's why I think these support groups are so important. These kind of meetings are so important, and why it's great when the industry is, in this case, involved in trying to support these presentations, because the more patients and their families and their doctors know about it, the better they're going to be treated, and the better they're going to be their quality of life, and the better they feel about themselves. So those are
Definitely.
the main thoughts.
Definitely. Another popular question within the group was, what causes the bloating? Because I know a lot of the gastroparesis patients have that distended belly and bloating, but they don't know why.
Yeah, it's a great question. I think it's probably multifactorial, which is, you could say, well, that's kind of a cop out, but some of it's the fact that the stomach doesn't relax, the upper stomach doesn't necessarily relax like it should to accommodate, and that happens. People feel very distended. Secondly, the pylorus doesn't open up right. People feel real distended, and then the small bowel also doesn't behave right. So as we've seen on the wireless motility capsule, the small bowel is dysfunction is abnormal just about as often as the stomach is. So I think it's a combination for any given patient. It may be they have problems with stomach, upper stomach, lower stomach, and small bowel, for example, or maybe just one of those three. But I think bloating is one of the earliest things that happens. One of the earliest symptoms that patients have. So it's a great question.
Thank you. Shelley, you have your hand raised. Can you unmute yourself?
I think I'm unmuted, aren't I?
You are. Okay, go.
Okay. So I have gastroparesis, but I also have a cerebellar ataxia,
Okay.
neurologic thing going on. And it's been hard for the coordination of both of them. I lost my doctor in Michigan, and then I went to Minnesota, but I can't go there anymore. I'm now in Southern Ohio, desperate to find a new doctor, and I don't even know like where to look. Most of the ones around here are pediatric people. I can go within a couple of hours of Southern Ohio, but because of my neurologic thing, I can't drive. Do you have any suggestions for any kind of where to look?
Well, it's always, it's very hard. The support groups can be quite helpful. As you're right, there is, I think, more interest in pediatric motility than maybe in adult. Or I think the interest is there, but maybe more acceptance. And that's a long story for that. I'm trained in both pediatric and adult. And I find sometimes it's easier to work in the pediatric regimen, so I'm not surprised. You can certainly contact anybody that's advertises they have a motility clinic, and those people can see you as well. I mean, our clinic in Kentucky sees people from all over, but unfortunately there's a wait to get in. But also most academic centers have somebody that's trained in motility, and the problem is they don't always want to see patients with gastroparesis because they're, as I said earlier, some problems are not clear and some solutions aren't clear, and gastroparesis is viewed as one of those. It's viewed as not a clear problem and not a clear solution. Now, those of us that work in the area trying hard to change that, trying to make it clearer, both diagnosis and treatment. But I certainly feel for you.
Thank you, Shelley.
Thank you.
Our organization also, although we're redoing our website, so you need to be patient, but we have a database online. So if you go to our website at agmdhope.org, we have a list of doctors. We also have within that list their clinical interests. So that may be able to help you pinpoint. I can't guarantee a doctor is on that list that may be near you or is still practicing, because again, that's something that has to be frequently updated, but just for your info, because we found the need to find doctors as specialists was tremendous. Thank you, Shelley. Pam, you had a question as well.
Part question. The first part is, why are gastric emptying tests not always accurate? And then how do you do that test if someone cannot have solid foods? The second part of my question is, I have rheumatoid arthritis and test positive for ANA and have short bowel and gastroparesis. Would IVIG be a therapy that might be able to help me?
The first part, gastric emptyings are, even though it's the gold standard, there are lots of problems. They're not always done with the recommendations. I've been on the council that recommends them, and I see them still not done the way they're recommended to be done. But there are also other ways to interpret emptying. For example, looking at the upper stomach, that can be done by computer, but not everybody's interested in doing that. So and then there are the people that can't tolerate, they're vomiting or they can't tolerate solids. And I deal with insurance companies. They say, well, the person doesn't have delayed emptying, and I have to point out to them they were vomiting and they couldn't do an emptying. And usually when it gets to an appeal with an insurance doctor, they understand that and accept that. But the bureaucracy is not set up to understand that patients are not all the same. I don't mean to be critical of insurance doctors because I work with them a lot, but frequently it requires a one-on-one conversation. Secondly, regarding the IVIG, yeah, you might certainly be a candidate for IVIG. It certainly has helped people. It's used in a number of autoimmune disorders, and depending where you're located, there are lots of people that do IVIG in the neuromuscular world. It's just finding somebody that wants to do it for when you have GI condition. But we get probably once a month, we get an email from somebody saying, I want to start doing IVIG on my GI patients. How do I do that? And we spend time with them. So there's increasing use of it. It has its drawbacks, but when all of those fails, it can be really wonderful.
Can you do infusions on top of rheumatoid arthritis medications?
I'm sorry, ask me the question again about.
Yes. Can you do the IVIG infusions on top of biologics and rheumatoid medications?
Usually you can. We always have to check. We have a pharmacist
list coming today.
Okay.
That's a great question.
Thank you very much.
Anybody else have a question before I start reading off some of the other questions that we got?
I do. I don't have the hand raise emblem. I cannot find it.
Okay, don't worry.
So Dr. Abell, hi again. You did my peer-to-peer for Blue Cross Blue Shield in 2019, I believe. And I had my stimulator placed in Kentucky at the motility clinic in 2020. But I had a pyloroplasty done in 2018 here in Tennessee. My new surgeon said that it's could be the way that the pyloroplasty was done, it could contribute to more acid reflux. If the pyloroplasty is causing problems, could it be repaired or become like more of a G poem? Or once it's done, is it done?
Good question. The thought is once you do the caloric therapy, that it's fixed. But on the other hand, just in general speaking, people that work with pyloric function a lot like things like the flip that I mentioned earlier, functional illumination, to try to see how the pylorus is functioning right now. And flip would be a diagnostic option. I don't know where you live right now who's doing that, but most, but not all major centers do a lot of flip right now, and many of those do pyloric flip as well. Originally designed for the esophagus, but so I would say that that could certainly be looked into. Could certainly be looked into further. I hope that's enough of an answer for you.
It
Thank you.
is. Thank you so much.
Good.
Dr. Abel, are there long-term studies on the GPOM? Because patients, from their responses, they're mixed results. Sometimes they work for a while and then it doesn't work. And then sometimes it just doesn't work at all. And some people are praising it. So the question has come to me is, are there any long-term studies for the success of that for symptom relief?
Well, there will be in the future, but there's not right now. I mean, the longest studies are out of 3-4 years versus things like devices that we have 30 years of experience with. But there aren't, which there need to be. And again, it can work. It can work very well, but it doesn't work for everybody. And there's certainly a group of people that it works for a while and then doesn't work as well afterwards. And so some people have advocated redoing the GPOM. I don't do GPOM myself. I'm not an expert in GPOM, but I have a lot of experience with taking care of people that have GPOMs. It's so promising that there will be more studies coming out about it, which will be good.
And we got quite a few questions on the pyloroplasty as far as the success for gastroparesis. So what is your feeling on that as far as I know you had it listed there as a potential treatment, but what is the success rate for that?
Looking at the double-blind randomized studies, most of which were in Europe, between 60 and 70% response.
Oh,
So it's good. Similar to what you see with devices, higher than you see with IVIG. If I talk about those three. But again, the question is, what everybody would like is to do any therapy only on the people that it's going to work on.
yes.
Whether it's drug, device, detoxification, disruption of sphincters, you want to be able to select those patients, and that's what we're trying to do with some of these other things like the body surface mapping and the flip and the antibodies. All of this is trying to say, yeah, this is what you need to feel better, and everybody has the same goal. But caloric therapy can be a real good thing. It's just finding the right person, and also finding not every physician that's an interventional endoscopist does GPOM. But you probably should try to talk to somebody that does a fair number of them, as with any procedure, to get that judgment.
Lisa submitted a question. Lisa, are you here? Let me just take a quick peek here. No, it doesn't look like she's here, but she wanted to know, how are mast cells related to gastroparesis?
Well, great question. the mast cells, back when people like Golgi and Cajal and were winning the Nobel Prize and other work around 1910, 1912. So over 100 years ago, people felt that mast cells were the key to everything going on in the gut. And there's some evidence now that for people that have dyspepsia, for example, non-delayed emptying, that mast cell and other inflammation in the duodenum, for example, is common and may be part of the problem. So mast cells are very important. We know the most about mast cells in disorders of mast cell function called mastocytosis, where people get an abnormal number of mast cells. And those people are probably not very common, but in those cases, we see specific things we can do for the mast cells.
Medication needs? No, ma'am.
The mast cells are very important.
It's on file.
Thank you. Thank you for answering that. Okay. Dr. Abell, as you can see, I have like this big stack of paper with questions. I just want to thank you. I remember the very first time that I communicated with you many years ago, and I was having a symposium, and you agreed to speak. And the first time that I met you, I could just tell, not only were you so knowledgeable, but the caring that you had, the heart for the patient was very evident. Just so sensitive, and you listened to the patients. And that was one of the first symposiums, actually, I think it was the first, that we had physicians, dietitians, scientists, pharmaceutical, patients and their families all in one setting. And we established that for all of our symposium and conferences because it was so successful. And you were a part of that. So I'm just eternally grateful for that and for still being dedicated to our nonprofit organization. So you are amazing. And I always close these programs in a similar way. Dr. Abell, you are one of my heroes, as are all of you patients. And as far as the patients are concerned, you're living this every single day of your life. I call you the quiet heroes, because you're not big actress or actor or sports thing, although you may be, but you just are going through such challenging times, and you epitomize the strength and courage that somehow you find to get through this. And it is such an honor for me to be talking with Dr. Abell, and an honor for me to talk and see all of you and know that help is on the way. There's that beacon of hope that Dr. Abell is. May God bless you all. Know that my heart remains with you every single day, as do my thoughts. And every single day of my life, I pray for each and every one of you. Thank you again, Dr. Abell. May God bless you all. Take care. Bye-bye.